All right. Male patient, mid-30s, twisting injury while roller skating. He's otherwise a pretty healthy gentleman. This is his ankle fracture here. A little bit higher, fibula fracture, medial mal. Hard to tell much on his scan, but you can see there, here's an axial view, and then I think it should scroll through here. So he's got a posterior mal with some interposed pieces, interposed articular pieces. What are you thinking for approaching this one? That's a pretty big posterior mal for this gentleman. What's your thought process on somebody like this?
Yeah, so I've gone to more doing the medial posterior medial approach. I wouldn't say exclusively, but I would say almost exclusively. I see more back of the tibia, and for me it's more routine now. I like going to the fibula from the direct lateral approach.
Yeah.
I'm just so used to it. I
So
know
just
how the fibula is supposed to look.
for context, like talk about how things have evolved over time. I mean, because you're talking about a direct lateral approach, but what alternative would you use before going to the from what posterior lateral approach?
Yeah, I would have done a posterior lateral approach, I think, of just maybe 2, 3 years ago.
Yeah,
I would have
prone,
gone. Yeah, prone.
prone.
I don't hate myself enough to do a posterior lateral in the supine position.
How about lateral position, posterior lateral approach? Ever?
Yeah, I've tried that a few times. I just think if you're gonna go lateral, like it throws me off just how I'm
Yes.
looking at things. I don't think it's that big of a deal to go prone. I try to do like when I do medial, posterior medial, I've done it both supine and prone. I check the patient pre-op before we flip them, like I'm ready to go prone, and I see if I bend the knee, if I like figure it for them, how much motion their hip has and everything. And if it's as good motion, if I can get them basically lateral, like their ankle lateral in the supine approach on the medial side, I stay supine.
Okay. Okay. So, how much does it depend on the staff that you have and whether or not you like your staff on whether or not you're going to go prone or supine for the day? Don't have
Yeah,
to
not
answer
that
that.
much. Yeah, not that
Don't have
much.
to
I
answer
mean, like
that.
but I think it has to do with like, I mean, with positioning is I think key. So it's like, I think it's easier also to image when you're supine as well.
For sure.
Like I think
Most definitely.
people are more used to it.
Yep.
And so I think there's a familiarity there. And especially if I think there's like a syndesmotic disruption, like in this fracture, that syndesmosis looks hurt. It looks wide. I don't know
Yeah.
if it is, but on
Well, it's
that
got
X,
something in it. I mean, it's got that piece of, so you almost are guaranteed that there's going to be some sort of syndesmotic disruption in this case, right? I mean, you would think.
I agree. I don't know how it wouldn't be. And if you look at the overlap in that middle X-ray, but it is suspicious for sure. Fracture it's a Weber C. The syndesmosis looks hurt on these X-rays. The CT also shows some widening.
Yeah. All right. So then going ahead to our plan, we already went through this. So, what about your sequence for something like this? That fibula is pretty straightforward, but in this case, I ended up going supine, went medial, and then through the fracture, retrieved those pieces, those fragments of bone from that posterior piece. Could have maybe argued to scope it as well. Some people talk about doing that. I don't think I actually did in this particular case. It would not have been wrong. My theory was I'm going to have that exposed. I'm going to be looking through the medial side. I'm going to be able to identify any intra-articular pathology. And if it's there, I can always address it. So a lot of times on these, I know they talk about osteochondral lesions, lateral side. I actually see a fair number on the medial side or medial shoulder of which is really where I want to see. So if I'm opening it to fix the medial mal anyway, I'm just going to take my time, flush the hematoma, and get a good look at it. What are your thoughts on arthroscope, joint inspection, and strategies for success?
Yeah, great question. So I go back and forth whether to scope them or not because a lot of times I'm doing this open like the medial mal and so forth, so I can see it. I do like use of the. I'll use like a small joint scope, like a nanoscope, to look at the joint many times and even just to evaluate it and to document the joint
Document.
injury.
Yep.
I think that's a big thing because, like you said, those medial osteochondral lesions, we see them, and I think
Yep.
they're underreported
Yep.
because I don't think people are like looking for them. I'll make a point to look for it, and most of the time you'll see it, or you'll see like the cartilage, almost like a fractured windshield, you'll see like a dent in the medial dome. And so I'll remark on that. I'll take an image of it. Many times I'll take photos of it. So I think they're very helpful. Just I wanted to make a comment here, just with your fixation strategy. So if you look at your far left X-ray and you just have a clamp, you've gotten the fibula out to length. It looks great. Okay. And many times you'll have your medial, if you know, if you're out to length, your medial malleolus, because of ligamentous taxis, should be fairly well reduced. So you've shown a couple X-rays in the past, and this one, I think like that, getting that fibula out to length really helps you get your other parts of the ankle fracture reduced as well.
Yeah. Well, and then vice versa too. Sometimes you have a pretty comminuted fibula fracture with a medial mal that's a little more straightforward, like your juicy medial mal, for example. And so fixing that sometimes helps just to pull it over. Now you know you've got that part reduced, and then you can have some benefit either way. So I think we all tend to think fibula first and then the medial mal, but it doesn't always have to be that way depending on the pattern. All right. So let's see. What did we do? And I really don't think, yeah, so in this case, I did not go medial posterior medial. I put a percutaneous clamp on, and then I ran placed a wire for a cannulated screw through a posterolateral incision, percutaneous posterolateral incision. Now, I see different strategies on how to fix this. I felt like the piece was large enough to fix in this case, and I don't know what your strategy is for doing this and how you would do it medial, posterior medial, because I guess that's my next question. So if you do a medial, posterior medial incision, are you now using that for your medial mal and your posterior medial, or are you doing two separate incisions for that?
It depends. In this case, I think I would have done two separate incisions based on the axial CT scan. But I really like what you did here. The one thing that I a lot of times will do now, though, you use that percutaneous wire from posterior to anterior. I go the other way, anterior to
Yep,
posterior,
that works. Yep,
and just because for me it's easier on imaging because I'm supine and like I mean it's hard to drill up. It's easier for me to drill down with a wire to get it where I want it, and I'll base it. This is where like that axial CT scan that you had in the
that's right.
beginning.
That's exactly right.
I do a lot of pre-op planning for this. Like I know what the measurement is. So I look, okay, like, you could see if you can you point out the tibialis anterior on the axial CT scan?
Tibant would be right.
Yeah, exactly. Exactly. So since you know where that is, you can feel that and palpate that during the surgery. So I'll put my screw or my wire just medial to that. And I draw it out, on the CT scan, and I know like, oh, that's supposed to be a 40 millimeter screw,
Yep.
44, 48, whatever
So
it
you can
is.
draw it out, and then you can run it. Well, it's not a straight line. Draw it out at your trajectory that you want.
Yeah. And so then I know, like, and if I measure when I put it in, if I'm measuring like 50, something's off. If I'm
Yep.
measuring 20, something's off, right? I
Yep.
should be within a couple millimeters, give or take. And so I know what that screw should be. So I'm not too long. And I know that at least I think I'm in the right trajectory. I don't actually know it, but I hopefully, hopefully I'm closer than I would be otherwise.
Well, and you have enough landmarks to know kind of where things are going. So then is that screw going from front to back, or do you run the wire out the back and then it run the screw retrograde?
Yeah, I run the wire all the way out and then put the screw back to front.
Yep. Now, I've done both of those. In this case, and kind of going back to what you were saying, when I looked at this and drew out where my trajectory would go, it's right now I know like kind of that same thought, where my hand's going to go. And I can see that incision is going to be right off the posterior lateral border of the Achilles. And if I make that incision there and run my wire in, it's a relative safe zone as well. I mean, you have to be a little careful for sural nerve, but I think you're close enough to the Achilles tendon that you're away from it in this area. And then, going back to where the screw ends up being, and there's a couple papers showing, strategies for placement of this posterior to anterior screw. You want to make sure that, because I've messed this up before, you've got to make sure on this view here that this wire, the start point of that screw head is going to be on the other side of this line on the tibia. on the lateral side of the tibia. And so that's what I'm doing here is I'm checking with my depth gauge to see where that screw is to make sure that I'm not putting it into the syndesmosis as opposed to putting it in or making sure it's right on the bone. Because I have had cases where I put it in, think I'm okay, screw head goes in too far, and now it's probably in the syndesmosis as opposed to right on the peak of that piece.
I've been there as well.
Yeah. But CT, what I like so much about like the way we're thinking about this is you're using CT scans to plan out where the screw is going to go and the trajectory of how you're going to hold your hand. And then you're using X-ray to kind of confirm it. The other thing I've done before, and again, different strategies is you can sometimes put that wire from the front to the back. You can actually see it come through the fracture. You know, in this case, it doesn't work out, but sometimes you open that fracture, you're looking through through that fibula fracture to the posterior piece where you can clean that area out. You can actually run the wire kind of in the middle of that, see it, but not put it all the way through until you get the fibula reduced. And then you kind of different strategies for fixing posterior mal. I definitely think the take home is we are being more aggressive with fixing these posterior mals because this is probably one that I don't know, a few years back, I wouldn't touch. What do you think?
Yeah, I agree. I think I'm a little bit more aggressive fixing it. It also depends on just their, you know, their area of instability. So if they like, dislocate it posteriorly, I'm much more likely than to fix their syndesmosis. I mean, not fix their posterior mal, I mean.
Yeah. Yeah.
Because I want to kind of like, it's one of my partners says, "What would the 5-year-old say?"
Yeah.
Or, and I'd
Yeah.
be like, "Yeah, the 5-year-old say like, yeah, fix that, push it back." So that's what I kind of do for
Tell your
those
partner
cases.
I use that line all the time. I think that makes a ton of sense. So thanks. Go ahead. You can keep talking about it.
And you could see there point out. So, like you mentioned, that the screw on that mortise view where the head of the screw is.
Let me see if I. So you can see here that I want that screw head to be inside where that tib fib clear space is on that mortise view. And same thing here. You see how the screw head sits? It sits like it sits right on the bone. If you get into the syndesmosis, it'll sit recessed when it gets all the way down. And that's just another clue that I've been off a little bit. So then here's a follow-up. I think I got roasted actually without me being there on this case by one of my trauma colleagues for fixing the syndesmosis without more evidence of instability in this case. And now talk me through like your thoughts. I personally, especially with flexible fixation, have a very low threshold in this particular case to go ahead and fix the syndesmosis because I'd much rather maybe be a little bit over aggressive. But I think there's subtle signs of instability. There's the anterior posterior. Sometimes you don't ever see that on a radiograph. But in this case, I know that there's probably enough findings to suggest there's syndesmotic instability in this case, and that just fixing the posterior mal may not be enough because that's another case for stabilization of syndesmosis is fixing the posterior mal. But what are your thoughts on that?
Yeah, so I don't believe that just fixing the posterior mal will get you, negate any reason not to fix the syndesmosis. I think that was often like that's kind of like sometimes a misconception or misinformation. I think it can help add stability to your syndesmosis, but your syndesmosis, like you mentioned, you could still have anterior instability, right? Your AITFL could be hurt and the central band of your syndesmotic ligament. So it doesn't makes all sense to me. Maybe your PITFL, yes, it's intact, but the other 2 out of 3 are not. And I I'm with you. If there's any subtle signs of instability on exam and so forth, I'm much more likely to put syndesmotic fixation, especially flexible syndesmotic fixation. I see little downside. There's a cost,
Cost.
okay? There is a cost, but the downside of missing much higher, right? If you miss it, in terms of arthritis, return to the OR, et cetera, much higher. So I think here it's kind of like if you think it is and you're questioning it, there's probably some instability. And so, and I think this may be an argument where if you know that there's like subtle instability, but it wasn't like you couldn't put the syndesmosis anywhere, right? It
Yeah.
was just
Yeah.
like moving a little bit. You're like, that's a little too much. The thing is, maybe this is a patient that you then are more confident allowing earlier weight bearing, right? Earlier return to activities because you have a belts and suspenders, fixation construct for your syndesmosis.
So then that's great lead into for somebody like this. I'll tell you what I do, and then I'd be interested to hear how you approach it. But somebody like this, when I have the syndesmosis fixed, that's kind of how I think of it. That I usually splint them for 2 weeks for wound skin protection, and then put them in a boot, let them begin range of motion, and let this person start to put a little bit of weight on it. But sometimes I hesitate a little bit on these posterior mouths because technically that's more of an articular fragment. Do I need to baby that patient a little bit longer, keep them non-weight bearing? How are you approaching that for this particular patient?
Yeah, I've gone all over with this one, from like early weight bearing to, I mean, like, you almost like don't let them weight bear almost forever. I think when we started residency, right, it was like almost like 3 months non-weight
Seemed
bearing.
like it.
And then I'm gone now to like, 2 weeks to 6 weeks. I kind of base it off also the patient, like, because if I need to hold them back, if I'm a little concerned that the patient might do too much, just in general, I might be like, oh, let's just wait 6 weeks, knowing that they're still going to do stuff, but maybe it may remind them to slow down a little bit. Um, so I'm pretty aggressive now with weight bearing and range of motion for these injuries, unless the syndesmosis was completely off. Like if you see like a log splitter injury, I'm a little bit more because I think then your intraosseous membrane beyond the syndesmosis is also injured in those fractures, right? It's not just locally at the ankle; it's up the tibia. So I'm a little bit much more conservative there, but this would be like 2 to 3 weeks. Once the wounds is healed, I'll be like, here's a boot. Start testing it out a little bit. I wouldn't have them like say, go running or going up and down stairs, but I'd be pretty aggressive here.
Yeah, I think so too. And I think, you get a feel too as you get farther along who you can, hopefully you get a feel. Sometimes you don't always know, but who you can trust and who's going to protect it a little bit and not be overly crazy and who you're like, I need to slow you down. I will say, diabetics, neuropathics, I think those are a little bit of a separate animal and they're probably going to have a different fracture pattern. So you do want to be careful for that. But for me, I totally agree. And the log splitter, that's one that you maybe argue you need screws on that. On the diabetic neuropathic, probably go to screws on those cases. What are your thoughts on that in terms of decision for types of fixation, flexible fixation versus rigid fixation?
Yeah, so I agree with you. If they're diabetic neuropathic, they get rigid fixation. If they're just like diabetic, but they're not poorly controlled, what I might do is I'm a big fan of like hybrid fixation. I put a tightrope in and then put a screw in, so it kind of gives a little backup. And I do the tightrope first. Helps me get the reduction because we know it works, right? We know it helps improve reduction. At least the studies support that. And then I put a screw to back it up, and I'll do that for, like, well-controlled diabetics, right? They're maybe but not neuropathic. Neuropathic patients, they get screws and
Different animal, totally different animal. And I think you just need to be thinking about those cases and be aware of it because you don't want to get fooled into thinking here's this final